First of all, thanks so much for inviting me here. Great thanks to Ashley for organizing all this. He has been absolutely wonderful with the emails and making sure that everything is in place. So a huge round of applause for Ashley. Thank you so much. All right. So it's a rare luxury for me to have 2 full hours to present the neurobiology of addiction. And I only have 45 slides or so. We're a small enough group that if something comes up as we go along and you have a thought or a comment or a question, raise your hand and we may be able to take it as we go along. And with that, let's just start. I have no disclosures, some basic learning objectives. What I want to do this morning is to give you an understanding of how we appreciate the addictive process from a neurobiological perspective in 2019. The way we're going to do this is we're going to start with a basic model, move on to the fundamentals of the neurobiology of addiction, then add to that some new neurobiological concepts before going into treatments and finishing up with some new directions. I'll just move that so I can just see a little bit where I'm going. Okay. So let's start with a basic model of addiction. Up until 1980 or so, people thought that addiction was primarily a moral failure. The weaklings of the world, the people who could not resist the temptations of drugs and alcohol, would be the ones who would succumb to addiction. And somewhere around 1980 or so, science came around and said, no, not so fast. Addiction is a classic neurobiopsychosocial illness, very much like depression and diabetes and hypertension and schizophrenia, all these chronic relapsing illnesses. And the true causes of addiction are these biopsychosocial forces. When these biological, psychological, and social forces come together in a particularly nightmarish fashion, they change something in the brain. We call that the brain switch. They flip the brain switch on. And from that point, the addiction tends to have a life of its own, to a very large extent, independent of the forces that set it in motion to begin with. Okay, let me say that, the whole thing again. What I mean here. There are biological vulnerabilities. There are biological reasons why somebody may be addicted. Genetics. If both your parents are alcoholics, no matter where you grow up, you have 7 times the chance of the general public to be an alcoholic yourself. Pure biology, pure genetics. There are psychological factors, and there are all kinds of things we can discuss there. The most popular psychological theory of addiction in 2019 is the self-medication hypothesis. People used to think that most individuals are perfectly fine and they start using the drugs in order to jump to some outside world. Self-medication hypothesis came around and said, no, not so fast. It's actually exactly the opposite. People feel alienated, people feel miserable, people feel depressed and anxious, and they use the drugs in order to normalize. People don't do drugs in order to escape. People do drugs in order to arrive. The classic premise of the self-medication hypothesis. And from a psychological perspective, most of us, that's how we appreciate addiction in 2019. Don't take me wrong. Sometimes people do drugs in order to get high. Sometimes people do drugs in order to normalize. Both these things are correct. And just to make things a little more complex there, sometimes people start using drugs in order to get high, and then they move to self-medication, and vice versa. There are elderly people who start using drugs in order to self-medicate insomnia, and then they start realizing that they can get high on those drugs. So both these are the 2 major psychological reasons why people use drugs, sometimes to get high, sometimes in order to self-medicate. And just to make things even more complex there is a 3rd reason that we are currently identifying as a psychological reason why people use drugs, outside of getting high and self-medicating, and that is performance enhancement. Anabolic steroids for sports, methylphenidate, Ritalin for better SAT scores, sildenafil, Viagra for better sexual performance. The performance-enhancing drugs. Very difficult to argue that people take those drugs in order to get high. Very difficult to argue that these people use these drugs in order to self-medicate. It's a third concept that we haven't fully wrapped our heads around, and it's a fascinating area for research. All right. That's for the psychology of the system. And then, of course, there are social factors. The microenvironments, the subcultures, the neighborhoods within which we all live and love and play and work that define the addiction. So when these three things come together in a particularly complex fashion, they do something to the brain, they flip that brain switch on, and from that point, the addiction is there to stay. This has clinical implications. A lot of our patients come to us with a fantasy that if only we were smart enough and good enough to go in there and find the original trauma, the original problem, unpack the traumatic experience, lance the boil, as Freud would say, express the past, relieve the pressure, then boom, they wouldn't be depressed, they wouldn't suffer from PTSD, they wouldn't need the cocaine, they wouldn't need any drugs, and they would be depression and trauma and addiction-free for the rest of their lives. Unfortunately, it's not as simple as that. Why? Because once you have flipped that brain switch on, if you have any chance of success treating your patient, of course you are going to try to address whatever depression, PTSD, anxiety, eating disorders, ADHD, whatever the patient may present with, of course you're going to do that, but don't expect that by simply doing that, boom, the addiction will go away. Why? Because of that very annoying brain switch that has been flipped on. Okay? That's it. I mean, that is pretty much everything else I'm going to say today is just bells and whistles on that fundamental concept of how we see addiction in 2019. Wonderful model. We believe it. We use it. Awesome. However, taken to the extreme, it suffers from a major flaw. It suggests that in the absence of significant biological, psychological, and/or social vulnerabilities, the risk of addiction is negligible. Let's think about this. You have a 16-year-old kid, and let's say that kid, that 16-year-old, has no biological vulnerability for smoking cigarettes. Her parents do not smoke cigarettes, her grandparents do not smoke cigarettes, no genetics of addiction whatsoever. Let's say that 16-year-old doesn't want to get high on anything, doesn't have anything to self-medicate against, no ADHD, no eating disorders, no anxiety, no depression, no trauma, nothing really of that sort. And let's say that 16-year-old lives in an environment where her peers do not smoke cigarettes. Her friends, her classmates do not smoke cigarettes. No peer pressure, no social stressor to lead to tobacco addiction. Would it be okay to go up to her and say, smoke away. You can smoke all the cigarettes in the world you want, and you will never become addicted to nicotine. Why? Because you lack the true causes of addiction, which are these biopsychosocial forces. How insane that would be, right? And that's why we have amended this model, and we have added use of the drug itself, the very molecules entering your body, as an independent additional cause of addiction. And that's a much fuller model of the addictive process. Unfortunately, what I just said is not theoretical. This is exactly the mistake that we made with opioids. What you have in front of you is one of the most frequently cited pieces of medical literature, an article that has been quoted over and over and over and over again. It's not an article at all. It's just 10 and a half lines. 10 and a half of the most damaging lines in all of medicine. Why? Because it gave us a ratio. And it said that people who do not have significant biopsychosocial vulnerabilities to addiction do not really have any risk of addiction. It quantified that negligible risk to addiction as 12,000 to 4. Out of 12,000 people who are going to be taking opioids, 4 will get addicted. The now infamous Porter and Zick article, non-article, there's again the 10 and a half lines, has been completely discredited, it has been put aside, but the damage was done. Generations and generations of physicians, including myself, were taught that you should not suffer from opiophobia, that if your patient has any kind of pain, prescribe, 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 prescribe. I started medical school in 1986 in California, and I was told in no uncertain terms that if I were to become one of those forward-thinking, new-age physicians, somebody who would be, the new generation, I would be having no problem with prescribing opioids. If you see any kind of pain, highest dose, highest frequency, highest duration, nothing to fear. And if anybody were to raise their hand and say, excuse me, isn't there a little bit of a problem here, perhaps, with addiction? The answer was very quick and very definitive. We have studied it, and we now know that the risk of addiction to opioids is 12,000 to 4. Always coming back to this infamous non-article that you have in front of you. And then, of course, the pharmaceutical industry took the ball and ran with it and capitalized on this medical mistake and started promising the world the world. If you have any kind of pain, if you are feeling like you're pins and needles, cancer pain, non-cancer pain, chronic non-cancer pain, doesn't matter, whatever it is, you take our lovely pills and you're going to emerge on the other side. You're going to be strong and beautiful and sexy, and all the wonderful things are going to be coming your way. Fully functional, nothing to fear. So yes, at the very core of the opioid epidemic was a medical mistake, but the pharmaceutical industry also has a lot to be blamed for really capitalizing on that mistake. The pharmaceutical industry went further than that and lobbied the government and lobbied the professional organizations like the Pain Society and managed to make pain the 5th vital sign. I see a lot of younger people here. You may not remember that, but there was a time when any person who would enter a hospital would be shoved these smiley faces and frowny faces on their face, and they would say, point here what your pain is. It doesn't matter, psychological pain, physical pain, doesn't matter, you had to point on those faces. And of course, if you had any kind of pain, boom, the JCHO, what the Joint Commission used to be called back then, wanted you to close the loop and wanted you to make sure that that pain is addressed in a universal fashion for everybody. Of course, people should have pain assessment. You're going to learn much more about it in the pain lecture. If they have operations, if they have cancer, there are pockets of the population that, of course, need to be assessed, but by no means a universal requirement as a vital sign. That has been thrown out, and thank God we don't do that anymore. But again, the trouble and the damage has been done. All right, this is a map of the United States in 1999. Lighter yellows show lower rates of admissions to emergency rooms for prescription opioids. Non-heroin opioids are prescription opioids. And heavy reds show higher rates of admission to emergency rooms for prescription opioid problems. This here is 1999, 2001, the South turns red. 2003, 2005, 2007, 2009. The first phase of the opioid epidemic in the United States. Let's be clear here. The majority of people who got addicted to opioids in Ohio and Kentucky and Tennessee and these really West Virginia, really very hard hit areas had no biopsychosocial vulnerabilities above and beyond the general public. Very often they were laborers, they had lower back pain, they went to the doctor, and boom, the doctor prescribed, an iatrogenic problem. And don't be fooled. Sometimes you're going to be hearing things like addicts display aberrant behaviors, meaning like the doctor shop and they do this and that. Of course, some of them do that. But the vast majority of people who got addicted to opioids during this first phase of the epidemic did not take a single pill above and beyond what the doctor prescribed for them. Not a single pill above and beyond what the doctor prescribed for them. What are those aberrant behaviors? Not really. Okay, shifting the blame there. You know, we're very good at that in medicine. All right, so that was the first phase of the epidemic. And somewhere around 2010 or so, people start getting a clue that something was wrong here. Legislation changed. I was very much part of those efforts, and I'm proud that I was part of those efforts. I think we did good. The prescription monitoring programs were put in place. Some of the formulations of the pills themselves became more difficult to abuse, to crush and inject, and so on. So all these were good things. So around 2010, the blue line is deaths by prescription opioids. And I don't know, if you stand on one leg and squint your eyes a little bit, you can convince yourself that the blue line is plateauing a little bit, which is fine. Great. But a little too late. By that time, you have made all these people addicted to opioids. You make the opioids less available to them. What are people going to do? Heroin. Heroin is cheap. Heroin is easily available. I do remember the time when you really could only find heroin in Baltimore and New York City. These days, you can find it anywhere. And most importantly, heroin is now pure. Heroin is so pure that you get almost the same effect intranasally than you get intravenously. Now that's huge. Since the HIV epidemic, young people have polarized what's acceptable and what's unacceptable, what is good and what is bad. Think about sex. Sex totally got polarized. Oral sex, perfectly okay, as you very well know, has become very much like kissing in high schools these days. On the other hand, intercourse is frowned upon, straight out of the HIV epidemic. Similarly, in the drug world, pills and intranasal use is perfectly fine, and IV, intravenous use, is frowned upon. So enter the purity of heroin in that kind of cultural change because of the HIV epidemic, and boom, young people have no problem starting to snort heroin. The majority of people who are addicted to heroin in 2019 do not use it intravenously, they use it intranasally. The second phase of the opioid epidemic with a skyrocketing of heroin deaths after 2010. And right when we thought that we have seen the worst and it cannot possibly get any worse and that was it, you know, we're done with it, boom, the third phase of the epidemic came in. This is a complicated slide. I'm going to try to explain it to you. The purple line is the prescription. On the y-axis we have mortality, we have deaths, and the x-axis we have a timeline. The purple line is prescription opioids, and you see here in 2010 the plateauing of the curve. The orange line is heroin, and you see here in 2010 how heroin skyrockets. And then somewhere around 2013, 2014, we have the introduction of the new agents, fentanyl and its analogs, things that look very similar to fentanyl, like carfentanil and the like. And as you see here, the green line is the sum of all these other lines. And as you see here, boom, it keeps on going up and up and up. Very recently, we may have seen a little bit of slowing down of the epidemic. There are some good signs out there that maybe a little bit of turning the corner. Not that it doesn't go up, but it doesn't go up quite as fast as in the past 3-4 years. And that's the full epidemic of opioids. Just to get a little bit of relative strength here, if this is how much heroin is needed to kill you, this is how much fentanyl is needed to kill you, and this is how much carfentanil will be needed to kill you. These analogs, like carfentanil, have 100 times greater strength than the original molecule of fentanyl. Okay, this is pretty much it for the epidemic. Any questions so far? All right, let's go now to the neurobiology of addiction, which is pretty much the third player. If you think about the medical mistake, the pharmaceutical industry, there is something to be blamed about how the system really works in our brains that makes things a little tougher. Okay? Let's unpack that brain switch. I keep on talking about flipping the brain switch on. What really happens inside that brain switch? That's probably the hairiest part of this talk, so let's try to concentrate on this part. Okay. I'll put this here so I can, okay, good. All of us have a system in our brains, the mesolimbic system, otherwise known as the pleasure-reward pathways of the brain. It's the same thing. It sits just above the spinal column right here in the more primitive part of the brain. And what it does is the following. It scans the world at all times for things that are pleasurable and rewarding. This system hovers around an area of the brain that's called the nucleus accumbens. It is innervated by dopamine and is very much part of being human. Imagine your very own dopamine level at this very moment at the nucleus accumbens, at the center of the pleasure-reward pathways of the brain, and it's about 100%. Nothing too good is happening, nothing too bad is happening. Your dopamine cells are firing about 100% of dopamine at the pleasure-reward pathways of the brain, right? If you had an amazing meal right now, not just the little muffins and things that we had there, and we're talking about a really amazing meal, chances are that the dopamine level at your nucleus accumbens would jump to about 150% of its baseline. Sex does twice the job of food and jumps the dopamine level at the nucleus accumbens to about 200% of its baseline. And these are the normal, everyday, pleasurable, rewarding things that we enjoy and kind of use in everyday lives, right? Now, out of 30 million chemicals that we have identified in all of the universe, there are only about 300 to 350 of them that have this particular ability to go smack at the same center of the brain and activate the mesolimbic system in a way very, very similar to food and sex. And these, of course, are the drugs of abuse. Most drugs of abuse jump the dopamine level at the nucleus accumbens to a little over 200%, 250%. You see cocaine here going over 300%, that extra oomph of cocaine. But that's what they do. Ultimately, from a neurobiological perspective, addiction is nothing else but the hijacking of the pleasure-reward pathways of the brain. That's what drugs of abuse do. And they do it quite effectively. There's one exception to this general rule, and that is the amphetamines and the methamphetamines, and crystal methamphetamine more specifically. If you see here on the y-axis, amphetamines jump the dopamine level at the nucleus accumbens to over 1,000%. Crystal methamphetamine, and the way that it's smoked, is probably more powerful than that. And a lot of people hypothesize that crystal methamphetamine jumped the dopamine level at the nucleus accumbens to 4,000, 5,000% of the baseline. It's the nuclear weapon in our brains as contrasted to the more conventional weapons of opioids and cocaine and alcohol and the like. It really is in a league of its own. Now, this has clinical implications because before crystal methamphetamine came to town, very big part of addiction treatment had to do with convincing the patient that life in sobriety would be as exciting, if not more exciting, than it was when they were drinking and drugging. When I learned how to do psychotherapy with addicted patients, this was very much part of my training. You can't look a crystal methamphetamine addict in the eye and say, trust me, sex in sobriety will be as exciting, if not more exciting, than it was when you were high on crystal methamphetamine. They will immediately know that you have not used the drug, you have not checked your textbooks, you don't know what you're talking about, and they will discredit you. And that's why we have devised other ways of talking with our patients. And in 2019, a lot of psychotherapy happens along the lines of trade-offs. Sure, if you want to be sober from crystal methamphetamine, you're not going to have that kind of sex again as what you had when you were high on crystal meth, but perhaps you may want to keep your teeth, or I don't know, you may want to keep your children, or you may want to keep your life, or there may be other things that may have some meaning, some salience for you. And that's what we do. That's the way that we deliver psychotherapy today. All right. The drugs of abuse come in, hijack the pleasure-reward pathways of the brain at the nucleus accumbens, and when they do that, the patient has flipped the brain switch, and the addiction has a life of its own, staying there for a long, long time, most likely for the rest of the person's life. Don't take me wrong here. I'm not saying that people who are addicted do not recover. As a matter of fact, the majority of people who at some point in their lives met criteria for a substance use disorder will end up beating the disorder. But the vulnerability to go back to using stays with you for a long, long time, if not for the rest of your life. Let's take an example there. Nobody wakes up one morning and says, I want to be a cigarette smoker. Yay, that's what I'm going to do. No. It takes several weeks, several months to become addicted to tobacco, correct? Let's say you do get addicted to tobacco and you smoke 2 packs a day for several years, and then you manage to quit. And you quit smoking for 20 years. For 20 years, you haven't had a single cigarette. 20 years in your sobriety, as you very well know, the body is incredibly forgiving. Your risk of cardiovascular illness has gone down to almost as if you haven't had a single cigarette in your life. The tissues repair from the neck down. You're quite healthy. So 20 years in your sobriety from cigarettes, something happens and you have a few puffs. Do you expect that it's going to take several weeks and several months to become addicted to tobacco again? Or you're going to go back to 2 packs a day within a matter of days? What's going to happen? You're going to go back to 2 packs a day within a matter of days. And the reason for that is the incredible permanence of the hijacked pleasure-reward pathways of the brain. The reason for the incredible permanence of the hijacked pleasure-reward pathways of the brain is their geography, is their anatomy. Just above the nucleus accumbens and a little bit to the side is the hippocampus, which is the memory center of the brain. Below the nucleus accumbens and part of the nucleus accumbens is the amygdala and the limbic system, which are responsible for emotions. So imagine the stronghold that these hijacked pleasure-reward pathways take on our existence when they are sandwiched between our memories and our emotions. And that's the reason why they're so darn permanent. Okay? Now, miles and miles and miles away from this whole drama that happens right here in the more primitive part of the brain are our frontal lobes, this part of the brain. And the frontal lobes are responsible for abstraction, rational thinking, cognition, planning, executive function, all these civilized things. Fortunately or unfortunately, the frontal lobes are not very well connected to the limbic system and the more primitive part of the brain. Below the age of 22, is there anybody here below the age of 22? All right, good. I didn't want to be no offense here. But below the age of 22, not even the hardware is fully developed between the frontal lobes and the limbic system. We're still putting down cables that connect our frontal lobes with the limbic system. That's how we start to understand the adolescent. The adolescent who falls in love and fails to see the light at the end of the tunnel is not that so much she or he does not have fully developed frontal lobes. This is part of it. But these kids can solve quadratic equations. They can do all kinds of very complex analytical things. The main problem is that they cannot recruit those frontal lobes all that easily to modulate an explosive limbic system. That's the problem. It's a connectivity problem. Now, this disconnect between our frontal lobes and the more primitive part of the brain survives in adulthood, and all of us get better and better at connecting and disconnecting the two sides. This disconnect, it's not all bad news. How do we start to understand the appreciation of the arts, or music, or a sporting event, or even having sex, unless we're able to disconnect the frontal lobes from the more primitive part of the brain? Think about it. The idea of allowing another human being to enter your body, or your body entering another human being, is absolutely absurd from a frontal lobe perspective. If it was left to our frontal lobes, we will never be able to have sex. We have to be able to suspend this apparatus here in order to engage in more primitive activities. And this is all nice and good, and that's how we live our lives, until your more primitive part of the brain has been hijacked by drugs of abuse. At which point, the one agency that you have that can keep the beast at bay, the one agency that you have that can actually keep an eye and make sure that you are safe, is not all that available to you because of that disconnect. Ultimately, the war on drugs becomes a war between the hijacked pleasure-reward pathways of the brain that scream, I want, I need, and the frontal lobes that try to keep the person safe. When the hijacked pleasure-reward pathways win, the patient relapses. When the frontal lobes win, the patient is in recovery. This is the two-part equation of addiction. When you see a patient who suffers from addiction in front of you, visualize in your head how strong are her or his hijacked pleasure-reward pathways versus how strong is her or his frontal system. If the hijacked pleasure-reward pathways overwhelm the frontal lobes, the patient relapses. If the frontal lobes are stronger than the hijacked pleasure-reward pathways of the brain, the patient is in recovery. Our job as clinicians is twofold. On one hand, we try to cool down that underlying engine the best we can, and we do that with medications when we have them available to us. And on the other hand, we try to beef up those frontal lobes the best we can, and we do that with psychotherapy and counseling. Very, very often, the combination of medications with psychotherapy and counseling tend to separate those two agencies the most, make the frontal lobes much, much stronger than the hijacked pleasure-reward pathways of the brain, and keep the patient the safest. Think about the power of group psychotherapy, the power of group counseling, the power of 12-step programs in addiction treatment. What happens in these group processes? You enter a room of peers, all of whom have been there, and they know the score, and they can start sensing that your nails start looking like the nails that you had when you were drinking and drugging, and the hair, and the attitude, and the language, and the affiliation, and all your presence start reminding everyone, whoa, there is some kind of trouble here. What are they doing? They are essentially recognizing faster than the smartest psychiatrists those brewing up hijacked pleasure-reward pathways of the brain that start exerting their pressure. They may not have overwhelmed the frontal lobes yet. Maybe they're marching towards the dry drunk. Who is a dry drunk? What's the concept of a dry drunk? Somebody who hasn't picked up yet, but is marching towards catastrophe. And the group can get together and say, whoa, I don't know, trouble, 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 do something. Go to a meeting, call your sponsor, go to your doctor, do something to reestablish the gap between your hijacked pleasure-reward pathways and your frontal lobes and stay safe. You're way too close to that line of overwhelming your resolve to stay sober. That's the power of the group. And it's incredibly effective. All right, any questions so far? This is pretty much about the basic neurobiology of addiction. All right. Things may come up later. All right. This is the basic concept. That's really 80–90% of what we do. In 2019, we have added 3 new neurobiological concepts, and I want to spend a little time talking about each one of those before we go into the treatments and conclude. Okay. Well, the basic concept, again, is the frontal lobes versus the hijacked pleasure-reward pathways, but we've added 3 different ideas here. First of all, the motivational circuitry, then the anti-reward pathways, and finally the concept of interoception. And everything I've said so far is I very much believe is evidence-based and pretty well established. What I'm about to say, these 3 concepts are a little bit work in progress, especially the anti-reward pathways. But we'll see what we can do with them. Let's start with the motivational circuitry. The way that I explained the model before is as if the drugs of abuse come in, hijack the pleasure-reward pathways of the brain, do this whole kind of stuff, and they leave the poor frontal lobes on their own. They can be strong, they can be weak, whatever it is, but the drugs of abuse don't really affect our rational thinking all that much. As it turns out, fairly recently, we have identified motivational circuits in the brain, motivational circuitry, in part of the frontal lobe, the medial part of the frontal lobe most specifically, that the drugs of abuse can actually go in there and give us false sense of rationality, the stinking thinking of addiction. Narcotics Anonymous said it many, many years before neurobiology caught up with things, the stinking thinking of addiction. When you think that you are operating as a rational human being and you put all these seemingly irrelevant decisions together, meanwhile, you are serving the purpose of the drugs of abuse, the very sneaky motivational pathways of the brain. And of course, motivational interviewing, the premier counseling and psychotherapy modality for addiction in 2019, capitalizes in working with those motivational pathways. The second concept has to do with the anti-reward pathways of the brain. I would like us to play a game first, and after we play the game, we'll try to put it together in terms of addiction. This is the concept that is the least well understood and fleshed out, but we're going to give it a shot. The people who came up with these ideas here, Tversky and Kahneman, both psychologists, won the Nobel Prize in economics because they showed that our brain distortions can be exploited and make millions. Well, we knew that, but they're ones that really showed it. Okay, so let's play the games, and then we'll see what meaning they have. I give you a choice. Think about this as real money. Choice A, I give you $250 to keep. Let it sink. Option B, you have to gamble. And if you decide to gamble, then you have, 25% chance of winning $1,000, 75% chance of winning nothing. Okay? Let it sit, the two choices there. How many people here would go for the sure thing? All right, raise your hands, yes. How many people here would gamble? All right, okay. I would say it's more like 85 to 15. 85% of the people would go for the sure thing, and 15% would go for the gamble. And this is pretty much, this is pretty much what we see in national samples as well. The majority of people would go for the sure thing, then some people would gamble. Obviously, these are the people who are more risk averse. These are the people who are more risk prone. These people here tend to see the world as a little more dangerous than it really is. People here tend to see the world a little safer than it really is. People here tend to overestimate harm. People here tend to underestimate harm. So this is kind of like a little bit of a personality that we have as well. Okay. Try to erase this game completely from your heads as much as possible, like it never happened. And let's play a completely different game now. All right. I give you two choices. Choice A, you give me $750. You open your checkbook and you write a check, you give me $750. Option B, you have to gamble. And if you decide to gamble, you have 25% chance of losing nothing and 75% chance of losing $1,000. Okay? Let it sink. Let it sink. Let it sink here. All right. How many people here would go for the sure thing of the $750 loss? All right. How many people here would go for the gamble? Absolutely. About 90% for the gamble, 10% for the sure thing, which is exactly what we see in national samples as well. Okay, what happened here? The first game spoke to your pleasure-reward pathways of the brain. It immediately spoke to your nucleus accumbens, to your dopaminergic system, and when you sensed the feeling of getting this pellet of fun of $250, you get a little bit of an uptick of your dopamine level at the nucleus accumbens, and you were pretty conservative when it came to those rewards. You want to safeguard whatever good things are happening your way. Yum, 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 I love those little $250 pellets of fun. Okay? Fantastic. The second game spoke to a completely different part of your brain, what we now call the anti-reward pathways of the brain. And when they get activated, you feel annoyed, restless, anxious, miserable, sometimes aggressive, the dark side of our existence. I hope that when you let it sink of giving me $750, that you felt the anger and the rage of doing that. That was the activation of your anti-reward pathways of the brain. And when it comes to that, you are no longer conservative. You'll do anything under the sun to make absolutely sure that you avoid the definite pain. And you would make sure to gamble to reverse that annoyance. Conservative when it comes to rewards, very, very risk-prone and gambling-like when it comes to pain. As it turns out, here's what happens with addiction. Every time there is a dopaminergic uptick, every time we have those graphs that we saw before where dopamine kind of goes up, there is also an activation of the anti-reward pathways of the brain, of that dark side of addiction. But in the earlier stages of a person's trajectory in life as an addicted person, the dopaminergic upticks, the dopamine things of the reward system overwhelm whatever little downticks you have from the activation of the anti-reward system. But as the addiction progresses and consolidates at the nucleus accumbens, what happens is the dopaminergic upticks become less and less and less and less prominent, and the anti-reward downticks become deeper and deeper and deeper and deeper and deeper. Ultimately, addiction morphs from the pursuit of excitation and reward to a frantic effort to avoid definite pain. And when it comes to the frantic effort to avoid definite pain, all logical thinking goes out the window, and the patient would really try anything she or he can to be at home. Doc, I save all week so I can go out on Friday night, buy as much cocaine as I can, use it so I can feel at home. The addressing of the anti-reward pathways of the brain, of the darker side of our existence. And this is not just by physiological tolerance alone. It's not just because the pharmacology of the drug necessitates that you use more and more and more of the drug. That's not it. It's a much more complex process. It's not just about dopamine. It has all kinds of other neurotransmitters associated with it that we haven't fully figured out yet. A much more complex system, most likely happening in a very different part of the brain, the habenula. But it seems that ultimately that is what defines the addiction much more than the earlier parts, which is all about pleasure and reward. Okay, of course I put here that psychology trumps probability, because if you play those games that we did before over and over again, you're not going to lose or going to gain any money. They're completely neutral, but of course our brain does not perceive it that way. Our brain perceives it in a distorted fashion, and that's exactly what gets our addicted patients in trouble. I don't know if you have familiarity treating any gambling patients, but gamblers very often talk about the tilt point, You go into the casino and you start gambling and you're pretty conservative, you lose some, you win some, blah, 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 and then you lost enough, and that's the tilt point where you have switched from a reward system to an anti-reward system, and then boom, after that you will do anything to avoid the definite pain, anything to recoup the losses that you had in the casino. And all rational thinking is out the window. Okay. And here it is. It's a study about that. These here are the reward system, and you see earlier it's all about the dopamine reward system, very little activation of the anti-reward system. But look at that, as we progress to the right, the upticks of the reward system become less pronounced, and the downticks of the anti-reward system much more pronounced. Finally, the third thing that we have added to the mix, the concept of interoception. I know there are a lot of things that I'm bombarding you with today, but this is it in terms of the concepts, the final frontier here. Interoception is one of the senses, very much like touch and sight and hearing and so on. It's a complex one, and it's a sense that tells your brain where your body is at any time. It lives at the insula, which is a part of the brain between the outer and the inner part of the brain. It's a kind of in-between. It's called the insula. And the insula is responsible for interoception. Interoception is a sense, is a function of the brain that takes all kinds of somatic signals. It takes all kinds of bodily signals, puts them together, integrates them, shifts through them, and decides what has meaning and what has not meaning. What am I saying here? Right this very minute, the room is too hot, the room is too cold, you may want to go to the bathroom, a fleeing sexual thought, an urge to go out and smoke a cigarette, all these kind of things. All these are somatic signals that your body keeps on sending upwards to the insula, and it's up to the insula through the concept of interoception to look at all those little things and say, okay, this has meaning, that has not. It's the final frontier before the information is sent to the motor cortex, before the information is sent to the actual ability to do something or not do something. I don't think I'm explaining myself too well here. Let me try to demonstrate the concept of interoception with an exercise. When I say so, we're all going to get up, not yet. We're all going to get up, close our eyes for 20 seconds. And during those 20 seconds, what I would like you to do is the following. For 20 seconds, I would like you to survey your body from the very top of your head all the way down to your toes for bodily signals, for somatic signals that are being sent to your insula. What is your body telling you at that particular moment? The idea is the following. Hopefully, for the last hour or so that I have been talking, all these bodily sensations have been there, have been coming up to your insula, but hopefully the lecture was interesting enough that your insula said, I'm going to ignore a bunch of things so that I can pay attention to the lecture. For 20 seconds, there's going to be no lecture, there's not going to be any other stimulus, and I would like you for those 20 seconds to allow your insula to fully experience all these bodily signals that are being sent at all times to our brain. Does that make some sense? All right, let's all get up. All right. And close our eyes. All right, that's good enough. We can sit down. All right. Can somebody tell me of something that they noticed that it was there now and it was there before, but it did not get appreciated by your insula before, and when you had that 20 seconds to yourself, you were able to experience it? Your breathing, absolutely. That's something that your body does that certainly keeps on going all the time up to the insula, and the insula says, hey, old news, I know that, doesn't matter, throw it out. Anybody else? Go ahead. Your shoulders are tight, absolutely. That's a very classic bodily signal that's being sent to the insula, and the insula has a choice of whether to give it meaning or not. Somebody else has something here. Knee pain, very similar, absolutely. This came about 10 years ago with the work of Nazir Naqvi, who published a study that showed the following. Nazir took heavy smokers who happened to have a stroke at the insula that obliterated their insula. And the ones who survived the stroke at the insula, not only they stopped smoking, a lot of people stop smoking after catastrophic events, heart attacks and strokes and so on, but what was amazing is that the people who had that stroke at the insula and survived reported no cravings for cigarettes. What happened to those hijacked pleasure reward pathways of the brain, and you have your addiction for the rest of your life and all that stuff that I've been talking about? What seems that happened with those patients is that the cravings for nicotine were absolutely there, they were fully there, they were being sent to the insula, but at the very last minute, the insula was not available to give them meaning, to say that this is an experience worth pursuing, and therefore they couldn't really appreciate their own craving to cigarettes. And that, of course, needless to say, opens a lot of avenues for research and for a renewed way of thinking about addiction. That very last step before the patient actually uses. All right. cruising along here. I'm delighted about that. I hope we will have a vibrant conversation, and we think about questions that you may want to ask me, and I think that would be very helpful to me. Maybe to you too. All right, let's go to treatments. What do we do for treatments? Our first crack at it was psychoanalysis, psychoanalytically oriented, psychodynamically oriented psychotherapy. That was back in the 1950s, 1960s. We didn't really have any other tools in our disposal. Anything the patient would suffer from, put them on the couch, hope for the best. That's exactly what we did with addiction, and it was a total disaster. Why was psychoanalysis such a failure to treat addiction? What psychoanalysis does best is to shrink the frontal lobes. That's why we are called shrinks. We are shrinks because we help patients shrink their frontal lobes, allow the more primitive part of the brain to take over, give permission to our patients to break some rules, go out there, have some fun, be happy. And it's not really all that difficult. You tell an addict, what I want to do with you is to shrink your frontal lobes so I can allow the more primitive part of the brain to take over. They're going to look at you as if you have 3 heads. If anything, the task is exactly the opposite. And that's why psychoanalysis was a huge failure. Second idea, the Synanon model from California, the boot camps. Let's lock them up, sometimes shave their heads, sometimes slap them around, confront the denial, break down those defenses, and then build the person from scratch. Terrible idea. The vast majority of people did not finish treatment. Even the ones who did finish the 2-year treatment were more damaged than actually helped with this kind of highly, highly confrontational models. And eventually that led to the third wave of addiction treatment, which is where we now live, where we do have safe and effective interventions for our patients. Treatments for addiction go along those 3 major buckets: medications, counseling, and mutual help. Absolutely not in order of importance. That's how they came out of my brain at that time. All right. Let's start with medications. Classically, in addiction pharmacotherapy, we have 2 major strategies, 2 major avenues. The first one is called an agonist strategy, and that is I give you a pill or a film or some kind of medication that resembles very much the drug of abuse. It goes into the brain, activates the receptors in a way very, very similar to the drug of abuse, and your cravings come down for the drug. Classic agonist treatment. Here we have increasing doses of the drug, and as you see here this is the wrong efficacy at the receptor level. Doesn't mean that one is better than the other of these medications. I should say activation here instead of efficacy. I'm sorry about that. Don't think that this is how efficacious the medications are altogether. It just simply means what they do at the receptor level. So ignore that word. So an agonist at higher doses goes in there and fully activates the system, therefore cutting down the cravings. Give me an example of an agonist strategy for tobacco cessation. The patch, the gum, all the nicotine replacement therapies. You put the patch on, your body sees the nicotine goes at the very same receptors in the brain, activates the system fully at 100%, cuts down your cravings for cigarettes, an agonist approach. For opioids, what would be an agonist approach? Methadone, absolutely. Goes in there, fully activates the cell, therefore your cravings come down. The opposite strategy is an antagonist strategy. And essentially that is, I give you a pill, I give you a molecule that goes in there, blocks the receptors so nobody else can come in and activate them. naltrexone for opioids. Goes in there, blocks the receptors like a false key into the ignition of a car. You turn it, the car doesn't go anywhere, the cell does not activate at all. After a while, you try to shoot up, you don't feel anything, you say this is too much trouble, too much legal exposure, too much money, why am I doing this? And you stop using. You get discouraged. The amazing innovation over the past few years in medication has been the introduction of a third strategy, of a third way of addressing addiction, and that is the partial agonist. Partial agonists do a little bit of both, or actually they do a lot of both. On one hand, they give you a shield, they block the receptors so other things cannot come in and activate them, but at the same time, they activate the system at the 40% level, cutting down the cravings. A wonderful combination of the two classic strategies of addiction treatment. Varenicline for tobacco, commercial name is Chantix, and that is a partial agonist to the nicotinic acetylcholine receptor, and you should absolutely use it for your patients who still suffer from tobacco use disorder. Remember, only the patients who suffer from the most severe form of the illness still smoke, and they do need their medication. Buprenorphine, by the commercial name of Suboxone, is the partial agonist for opioids. Major advantage of buprenorphine, of Suboxone, over, let's say, methadone, is the fact that you can only go up to 40%, and your risk of overdose and the risk of respiratory depression, coma, and death is negligible with buprenorphine. The other major advantage of it also can be prescribed out of a doctor's or nurse practitioner's or physician assistant's office, and you don't have to send your patient to an opioid treatment program, to a methadone clinic, which of course you have to do for methadone. We love methadone, think it's a wonderful intervention, but it is not the first-line treatment for opioid use disorder in 2019. Buprenorphine is the first-line treatment of opioids in 2019. Okay. Second up, counseling and psychotherapy. The grandparent of all these effective treatments is cognitive behavioral therapy, and we do a lot of cognitive behavioral work, which of course, as you very well know, combines thoughts, feelings, and behaviors, tries to identify these automatic thoughts, behaviors, and feelings that we have, and then try to punch some holes in these automatic thoughts, feelings, and behaviors, and give people alternatives. Wonderful intervention, cognitive behavioral therapy, but it does require significant motivation. If you're going to be doing CBT the correct way, there's a lot of homework, there are a lot of forms, there is a lot of structure to it. You can't really start doing CBT for somebody who feels that they want to change nothing in their lives. I don't know if you remember, but we used to say the horrible thing to our patients: come see me when you are ready. I've got nothing to offer to you unless you are ready to change. It wasn't because we're mean people. It was because we did not have the technology to really address people who were in the pre-contemplation or contemplation stage of change. We really didn't know what to do with these people. Now we do, because we have motivational interviewing, and motivational interviewing can do a great job with people who want to change nothing in their lives, or they are very, very ambivalent about making any changes. I hope that everybody here is trained in motivational interviewing. If you are not, that would be a good suggestion for people to bring some training in motivational interviewing. I'm just going to give you an example of one of the tricks of the trade. Here we have a readiness ruler. You go to your patient and you say, on a scale from 1 to 10, how ready are you to change, to quit drinking or stop smoking or whatever it is? And let's say the patient is in the pre-contemplation, contemplation stage of change, and they say, I don't know, I'm like a 2 or a 3 out of 10. Classic addiction treatment, classic CBT treatment would say, okay, Let's roll our sleeves up here. You're a 2 or a 3 out of 10. What can I do to make that a 4 or a 5? What kind of obstacles can I take away, remove from in front of you so you can advance towards quitting smoking, quitting drinking, quitting heroin, whatever it is? Motivational interviewing turns the whole thing around and says, you're a 2 or a 3 out of 10. I would have expected that you would be a 0 or a 1. How come you're a 3 and not a 2? How come you're a 2 and not a 1? Forcing the patient to put the little crumbs of motivation that they have in their own words and then capitalizing on that. I love my smokes, there's nothing wrong with them, it's all kind of propaganda and whatever. Well, aren't you concerned about your lungs and your head? No, my father smoked 2 packs a day and he lived to be 102 years old. Okay, what about your children? Are you concerned about the children, the secondhand smoke and so on and so forth? No, the kids can go outside and play, they don't need, How much money do you pay for your cigarette? I pay $30. What would you do with $30 extra a day if you were not smoking cigarettes? I would play the horses. Boom, you found it. You found a tiny discrepancy between where the patient is at and where the patient would like to be. You found a true motivation for the patient to quit smoking, and then you can start with these little crumbs of motivation and capitalize and make the person ambivalent. Most of medicine strives for resolving ambivalence. We want our patients to leave our offices being more confident than when they came in, not in motivational interviewing. In motivational interviewing, in the earlier stages of change at least, you want your patient to leave your office more confused than when they came in. You want to make them more ambivalent than when they came in. You want to shake that whole thing. And it's quite effective and very well established and very well easy to learn. All right. Finally, 12-step. This is a very old study, and I feel embarrassed a little bit that it's so old. It's 1996. We did it at Bellevue Hospital, but we haven't duplicated it since then. But I think it is quite telling. All right. We asked our medical staff to rank 11 things that are helpful in people's recovery. All 11 of them have evidence behind them, and we say, okay, what do you think is most important for people's recovery? And the medical staff put at the top there housing and government and medical services, very respectable things that, outpatient treatment. And at the very, very bottom of the list, AA, spirituality, God, inner peace, these were at the bottom of the list. And then we went and we asked patients to rank these 11 things that are most important for the recovery. And a very different picture emerged, where inner peace and God and AA were quite high up on the list, and government and outpatient treatments and things on the bottom of the list. Very different appreciation of what's helpful to them than what the medical staff felt. And then Lisa Goldfarb had the amazing idea of going back to the medical staff and asking the following question. We asked the medical staff, what do you think the patients think is most important for the recovery? What do you think, doctors, the patients think is most important for the recovery? And look at that. Once again, housing and outpatient treatment and medical services on top, God and spirituality and AA and inner peace at the bottom. So, not only we live in a very different page than our patients, we don't even have a clue what that page is that our patients live in. A huge disconnect between the medical establishment and our patients. The majority of physicians pay lip service to AA. And I bet you don't really want to go to AA either, right? Okay, check. I asked my patient about AA. It's a huge intervention. It literally helped millions of people around the world. It is free. It is easily available, and has changed people's lives around. It's absolutely our responsibility to make a very sincere effort to recommend 12-step programs to our patients. Are they for everyone? Absolutely not. there are a lot of patients who are not going to take to 12-step programs for one reason or another, and we have alternatives for them, but that does not mean that we shouldn't recommend the 12-step approach to our patients, given how much evidence now there is behind it. Okay. Couple of words about new directions, where we go from here before we close. First one, I bet several of you had thought that I'm going to be going there, is mindfulness. What we're trying to do with mindfulness is essentially duplicate the stroke at the insula. Nobody is suggesting to go in there and do psychosurgery and take pieces of anybody's insula out. But what we do think may be quite helpful is to try to trick the insula in not giving meaning to those cravings. I see people trying to read this. Between stimulus and response, there is a space. In that space is our power to choose our response. In our response lie our growth and our freedom. A wonderful quote that actually shows you that right there, right at the cusp, right when the hijacked pleasure reward pathways of the brain are about to overwhelm the frontal lobes, that very moment there may be an opportunity to trick the insula not to give meaning to that incredible, powerful craving that the person has and keep the patient safe. How do we do that? We sharpen their observing ego, as we say in psychiatry. We make them hyper-aware for themselves. We have exercises where they can, let's say, they can look at their craving as a suitcase in a baggage claim area at the airport, and you see the craving and it comes next to you. You have a choice. You can pick it up or you can let it be, and you know that's going to be coming back again. And these kind of tricks so that the insula decides to at least temporarily ignore the craving. In which case you buy time. Every craving has a beginning, a middle, and an end. The idea there is to try to ride the wave of the craving, experience the plateau and the resolution, and stay safe and not use. That's the idea behind it. We haven't crossed all our T's and dotted all our I's. It was one of the most difficult decisions that we made a couple of years ago when we wrote a book on mindfulness, because the evidence was not really all there yet. But we thought it was such a promising intervention that we had to write something about it. And finally, the final slide of the day today, back to psychodynamics. It may be that Freud is not dead, and maybe there is part of Freudian good old psychoanalytically oriented, psychodynamically oriented psychotherapy that still may be helpful in several situations. Here's one of them. NISARC is the biggest study, household study that we have for substance use disorders. And one of the wonderful things that NISARC did is when it addressed sexuality, it addressed not only identity and behavior, but also attraction. As you very well know, sexual orientation can be broken down in 3 different variables. Sexual orientation identity. Do I see myself as straight, gay, bisexual, or neither? Sexual orientation behavior. Do I sleep with men, women, both, or neither? And then sexual attraction, sexual orientation attraction, which is a more of a dimensional variable that goes from completely gay to completely straight and everything in between. Very much like the good old Kinsey scale from 0 to 6. So when we start analyzing, on the y-axis here we have substance use disorders, and on the x-axis we have a measure of sexual attraction. The shape of the curve is very similar between men and women, so let's just stick here to the left with women. What do we have here? In yellow we have straight, green we have gay, red is bisexual, and then we have these very interesting areas here where people are almost straight but not entirely, or almost gay but not entirely. It seems that people who live in these areas may experience higher stress than other people, and therefore that higher stress may be resulting in increased substance use disorders. So the idea there is there that psychodynamically oriented psychotherapy that does its best job with sexuality, with unpacking people's motives, to decompressing people's ambivalence that they may have with all kinds of sexual feelings that could very well be very helpful to these patients, decreasing the stress of living in these almost gay but not entirely, almost straight but not entirely areas, and therefore decrease the risk of substance use disorders. New ideas, this is where we're going, we're not fully there yet. Wait. A few more things to say, and half an hour, so plenty of time. Okay, let's review what we learned today, some of the conclusions that we have along those 5 chapters that we discussed. When it started with the opioid epidemic, and what we elucidated there was the 3 major components of the opioid epidemic, the 3 major causal factors of the epidemic, the major medical mistake that said that if people do not have significant biopsychosocial vulnerabilities, they are safe to be given opioids, and that has been debunked, and that was a major cause of the opioid epidemic. The responsibility of the pharmaceutical industry in promoting false data, and of course the neurobiology of the system, the way that our brain works, that makes the flipping up of the brain switch pretty darn permanent. In terms of the fundamental neurobiology of the system, addiction is the hijacking of the pleasure-reward pathways of the brain. The classic way of looking at that is the war between the hijacked pleasure-reward pathways of the brain and the frontal lobes. When the hijacked pleasure-reward pathways win, the patient relapses. When the frontal lobes win, the patient is in recovery. The 2-part equation of addiction. We have added to this basic concept 3 novel neurobiological ideas: the motivational pathways, where drugs actually give us the false sense of rationality, the stinking thinking of addiction. We added the anti-reward pathways of the brain, the dark side of addiction, the sense of anger and rage and misery and discomfort, which are very dangerous because when we feel this kind of activation of our brain, we take lots and lots of risks. And finally, the concept of interoception, the integrative function of the insula that takes all kinds of cravings and other somatic signals and decides which ones are to be given priority, or which ones are to be given meaning, or which ones are to be given existence, if you like, and then ignores the rest. In terms of treatments, the most relevant ones in 2019 are the partial agonists, varenicline for tobacco, buprenorphine for opioids. Let me just stop here for a second. The treatment of addiction in 2019 continues to be primarily psychosocial. 12-step programs, counseling, psychotherapy, inpatient programs, intensive outpatient programs, partial hospitalizations, rehabs, all these are the real true blocks of addiction treatment. For 2 addictions, and 2 addictions alone, we have managed to have really strong medications: tobacco and opioids. It's an absolute shame not to be using those medications that we have for tobacco and opioids. They are strong enough, they can carry the burden of illness in their shoulders, and absolutely we owe it to our patients to recommend medications for tobacco and opioids. We do have medications for alcohol as well. I use them, I think that people should use them as well, but they're adjuncts. They're just helpful. They're kind of on the side. For tobacco and opioids, they're the main fare. We talked about motivational interviewing, primarily for people who have very little interest in changing anything in their lives. The 16-year-old who uses cannabis excessively, very difficult to do formal CBT with that patient. You'd go with the motivational interviewing techniques. And finally, of course, the 12-step programs internationally having had tremendous success changing people's lives around, and particularly AA. Then finally, in terms of new directions, 2 major avenues. One is mindfulness, trying to trick the insula into ignoring significant cravings for the drug and keeping the person safe, and perhaps a return to Freud and to psychodynamics for some people who may experience particularly strong intrapsychic conflict, in which case psychodynamic psychotherapy may be particularly helpful to them. Thank you so much.